Coming to the last part of the rhinology, so it's very easier part. So facial bone trauma. Okay. First, we'll start with nasal bone fracture. The nasal bone is the most common bone to get fractured among facial bones. Point number one. Okay. Sometimes nasal bone fracture can coexist with nasal septal fracture. Okay. So if both bone and septal fractures are happening simultaneously, we're giving classifications such as chevalet fracture and then Jargeway fracture. Okay. Chevalet fracture and then Jargeway fracture. Fine. So in chevalet fracture, we are giving blow from below, vertical fracture like this. In Jargeway fracture, blow from front, horizontal fracture line. Understood? Now, undisplaced fracture without nasal deformity, you don't need any treatment. Undisplaced fracture, without any deformity, you don't need any treatment. One second. ₹700, sir. 780, sir. அது போட்டா போட்டு ஓகே சரி நான் பண்ணிடுறேன் ஓகே. So undisplaced fracture without nasal deformity, no treatment. Displaced fracture with nasal deformity, don't do till 5 days. Okay, no surgery should be done within 5 days because edema will affect it so much. 7 to 21 days, the edema is there, but it has been reduced. So the best time to do surgery is 7 to 21 days. Don't do after 21 days because fibrosis will upset. See, look at this picture. This is a picture of fracture nasal bone, which is undisplaced. Okay, undisplaced fracture nasal bone. Okay, fine. So how we are going to treat this condition? So we are having either close reduction. So the close reduction can be done for nasal bone with Balsham forceps, for Ash forceps, nasal septum. I'm going to show a demonstration of nasal bone fracture reduction. So this is a patient for whom Balsham forceps has been introduced and nasal bone fracture reduction has been done. So Balsham forceps introduced and nasal bone fracture reduction has been done. This is done under local anesthesia. That's enough. Okay. This is how a nasal bone fracture reduction will be done. Clear? The second nasal facial bone to get injured is leaf-foot complex of fractures. If there is maxillofacial injuries, okay, we call it as leaf-foot fracture. The first one is only over the bottom of the nasal. See, this is the only over the bottom of the nasal piriform aperture. So this part will be floating. So floating maxilla is called Guarin's sign. Floating maxilla is called Guarin's. Type 2 is involvement of nasal bone, zygoma, inferior orbital rim, then maxilla. So type 2 is a pyramidal fracture. It's a transverse fracture line. It's a pyramidal fracture line. It's a craniofacial disjunction. Craniofacial disjunction. Okay. So it's nothing but a fracture completely dismantling the skull base with that of the maxilla. So dismantling skull base with that of the maxilla. Clear? This is Leaford complex fractures. Leaford complex fractures. Clear? So zygomatic fracture, the sign is tripod sign. Floor of orbit fracture, you call it by blowout fracture, you could see teardrop sign. These are the two important one-liners concerned with zygomatic fracture and floor of orbit fracture. So if you injure the optic nerve due to trauma, you could do optic nerve decompression within 24 hours and with steroids. Now the important topic, CSF rhinorrhea. The CSF rhinorrhea can be due to surgery, spontaneous due to obese patient or trauma. So if it is a spontaneous or iatrogenic, which is a surgery-related leak, it is commonly seen over the cribriform plate of ethmoid. Traumatic CSF leak is happening over the fovea ethmoidalis. Okay, traumatic leak over fovea ethmoidalis. So what are the important clinical features of CSF rhinorrhea? You could see whitish serous discharge coming out of the nose. Okay, which is non-sticky. So as it is non-sticky, when you collect it over the kerchief will not go for some stiffness. Okay, the kerchief will remain the same. Whereas when you get cold, common cold, then handkerchief will become stiff after wiping out the nasal discharge. Here, wiping out the nasal discharge will not make the handkerchief become stiff. So this is called handkerchief test, which is positive in CSF rhinorrhea. Number 2, there will be a small leak present in the patient. So you can't be obviously seeing the leak every now and then. So you ask the patient to lie down. After quite some time, you ask the patient to bend forward. You will be getting a reservoir sign positive. So this is the reservoir sign seen in CSF rhinorrhea. Okay. See, bending forward, the patient is having a gush of CSF fluid. Okay. When normal position, you can't see that gush of fluid. Ask the patient to lie down for some time. The CSF fluid will collect for some time and it will bend forward. This is reservoir signs found in nose. There is also reservoir sign that we already see in mastocytosis. That is different. This is different. Okay. This is reservoir sign or teapot sign. Both are same. Okay. Third one is halo sign. See, consider if the patient with trauma and the trauma has resulted in CSF leak, it is called traumatic CSF rhinorrhea. You collect the CSF fluid in a white cloth. When you see that, you will see blood getting settled in the middle, CSF getting settled in the periphery. This is called halo sign. Why this is happening now? Due to difference in the specific gravity. Specific gravity of blood is higher than the CSF. So due to this reason, blood settles at the center, CSF settles at the periphery. So this is called halo sign. Okay, halo sign. All are gold mine of MCQs. You will see a lot of MCQs CSF rhinorrhea. They may ask a lot of questions from CSF rhinorrhea. Should be very clear. The important and gold standard investigation of choice is CT cystonogram. You will do a lumbar puncture, inject a contrast. That contrast will reach the cysternal spaces of the paranasynapses. That is called CT cystonogram. Okay. Next, if you are still not sure about the surgery, you should be introducing intrathecal fluorescein dye before surgery, and after surgery you could see the leak site very, very clearly. This is called intrathecal fluorescein dye before surgery. Clear? Or else you collect the nasal discharge, you do a CSF analysis for beta-2 transferrin and beta trace protein. So these components are very much specific for CSF fluid. So this, if present in the nasal discharge, it confirms that it is CSF rhinorrhea, whereas it is not present in nasal discharge. So CSF analysis can be done. So what is the treatment for this patient? You identify the leak site, you freshen the margin, you do CSF leak repair. Okay, that completes the. So we could solve still more MCQs from nose. A doctor posted in ICU and came to ENT opinion on April 2020 with the last hospital test for 3 to 4 days. Look at the year, that is very important. There is no history of trauma. What is the next step of management? Please answer. What is the answer? Answer, people. Jaiprakash, Dr. Jaiprakash, Dr. Gaurav, Dr. Tamil Nasan. So 2020, if someone has loss of smell, what could be the immediate diagnosis that you think of? Not now. You think of 2020. What is the diagnosis that comes to your mind? Why patient will be having anosmia? What could be the cause? Please answer. At least what could be the diagnosis? The options you are not filling now, it's okay. But what could be the diagnosis that comes to your mind? Hello. Hello. We are running out of time. Okay. So Dr. Gaurav has answered HRCD scan. Okay. It's simple. April 2020, someone is having loss of smell taste for 4 to 4 days. Now, it is suspicious of COVID-19. Okay. If it is COVID-19, I should immediately take a nasopharyngeal swab to confirm COVID-19. Okay. Fine. Next one. A boy fell down and presence with deviated nose. Though the septum appears to be in midline, there was presence of nasal bone fracture with cryptus. So, nasal bone fracture is confirmed. Okay. So, what is the answer? This is August 2020. Nasal bone fracture with crepitus. What is the next step to be done? Next step to be done. So, you should do a close reduction after edema subsides in 7 days. Okay. That is the answer for this question. A lady comes to OPD after fall from scooty. Her vitals are stable. She is having continuous clear watery discharge from nose after 2 days. Most likely feature of, what is the answer? Very easy. It's a CSF rhino, just which we saw just now. Okay. It's a clear continuous water discharge is confirmatory of CSF rhinorrhea. That is very much clearly given in the history. Okay, fine. So we can enter into pharynx. Okay, the pharynx divided into nasopharynx, oropharynx, laryngopharynx. So first we'll see about the nasopharynx boundaries. So nasopharynx, the roof is skull base, posterior wall is vertebra, lateral wall we are having fossa proximal, which is a hidden space, torus tubaris, and eustachian tube opening, anteriorly nasal cavity, inferiorly oropharynx. Very important. Now we are having 3 important lesions over the nasopharynx. All the 3 are very important. They will ask at least 1 MCQ from these 3 topics. Okay, very important. Never leave it. So nasopharynx boundary we know very well. So posteriorly vertebra, superiorly skull base, laterally eustachian tube, that you should never forget. Okay, fine. JNA, juvenile nasopharyngeal angiofibroma. As the name goes, it affects only the juvenile age group, adolescent males. Nasopharyngeal, it occurs at the nasopharynx. Angiofibroma, as the name goes, it's a highly vascular tumor. Okay. So what is the presentation? Yeah, 12 to 15 years male child, male boy comes to us with profuse epistaxis, nasal obstruction, frog face deformity. This is a typical presentation of juvenile nasopharyngeal angiofibroma. Okay. First, what shall we do? The commonest site of JNA is sphenopalatine foramen. The commonest site of JNA is sphenopalatine foramen. The hormone that is thought to play a role in JNA is testosterone. Okay, testosterone is the hormone that is thought to play a role in JNA. Now, you should take an investigation of CT facial bone axial cut. See here, this is normal. See here, the pterygopalatine fossa completely invaded with the tumor of JNA. It is pushing the posterior wall of maxilla anteriorly. It is pushing the posterior wall of maxilla anteriorly. Okay, this is called Holman-Miller sign. This is called Holman-Miller sign. Clear? What you're going to do? You should do surgery. Okay, and you should do radiotherapy if there is intracranial spread. Okay, you should do surgery or you should do radiotherapy if there is intracranial spread. So JNA very important. Adolescent, males, testosterone, highly vascular tumor, you should do surgical excision. Holman-Miller sign, very important. Next, Carcinoma nasopharynx. Okay, carcinoma nasopharynx. The ethnicity is Chinese ethnicity. Very important point. So Chinese population mostly getting it. The virus is Epstein-Barr virus. The HLA phenotype is HLA-B7. HLA phenotype is HLA-B7. The commonest site of CN nasopharynx is fossa of rosemulla. Very, 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 very important point. Okay. See here, this is the area of CN nasopharynx. It is spreading laterally, anteriorly, posteriorly, superiorly. Everywhere is this. What is causing? If it goes superiorly, it goes to skull base, causing skull base metastasis. Very important. Then if it goes laterally, I've told you already, Eustachian tube is there here. If Eustachian tube getting involved, it leads to serous otitis media. The patient will be having conductive hearing loss and ear blocking sensation. Posteriorly, go for vertebral metastasis. That you know very well. Anteriorly as obstruction epistaxis, that is very easy. The important thing is inferiorly goes now painless cervical lymphadenopathy. It is the most commonest presentation. Which is the most common presentation of CNS nasopharynx? If they ask now, it is painless cervical lymphadenopathy. It is painless cervical lymphadenopathy. The CNS nasopharynx, Chinese population, Epstein-Barr virus, HLA-B7, starting from fossa of rosemulla, going anywhere from the nasopharynx. The treatment is radiotherapy. Okay. The important triad that is missed is if the tumor goes more superiorly enters into foramen called sinus of Morgagni. If the tumor reaches sinus of Morgagni, it causes a triad called Trotter's triad. Absolutely important. Temporoparietal neuralgia, number 1. Palatal palsy, number 2. Conductive hearing loss due to involvement of Eustachian tube, number 3. These 3 are the important triads that could cause if the sinus of Morgagni will be affected. Okay. Affected. Clear? Fine. So we have completed anatomy of nasopharynx. Then JNA very, very important. Then CN nasopharynx also important. The third one is adenoid hypertrophy. So adenoid is nasopharyngeal tonsil. We are having a lot of tonsil present over the upper airway. Nasopharyngeal tonsil, palatine tonsil, lingual tonsil. Then posterior pharyngeal bands. Okay. So all these tonsils are lymphoid structures, whereas if the lymphoid structures keep on getting infection every now and then in a child, it will lead to nasal obstruction and snoring. Usually, the epithelium of the adenoid is ciliated columnar epithelium. It is a ciliated columnar epithelium. So, what are the features of adenoid? So, the patient, due to chronic nasal obstruction and mouth breathing, they will have a lot of anatomical changes over the face. Number 1 is high arched palate. Then crowded maxillary of teeth. Then loss of nasolabial fold, pinched up nostrils, sunken eyes, pursed lips, elongated face, short upper lip, and hypoplastic maxilla. So these are the features of adenoid hypertrophy getting very severe. So if this is the case, the patient should go for adenoidectomy. Once we do this, the patient will be absolutely relieved of symptoms. Okay. Fine. Now, the second part of pharynx, okay, deep neck space infection. What is a deep neck space? First, we have to know the cervical fascia. We are having 2 fascias. One is superficial cervical fascia surrounding the platysma. Deep cervical fascia, which is divided into investing layer, pretracheal layer, prevertebral layer, 3 layers. Okay, out of which investing layer is very important. It almost encloses all important structures of the neck and the lower half of face. Okay. Now you look into this. Retropharyngeal space is found between buccopharyngeal fascia. Okay, found between buccopharyngeal fascia and alar fascia. Retropharyngeal space is found between buccopharyngeal fascia and alar fascia. Very, very important point. You spend at least 4 to 5 hours after this class gets over. You will be thoroughly revising the ENT. Okay. Retropharyngeal space abscess. Okay, it occurs posterior, so it's a midline bulge. Posterior midline bulge is retropharyngeal abscess. See, the name itself implies retropharyngeal, just behind the pharynx. Posterior midline bulge is the retropharyngeal abscess. The cause, acute in children, dental caries. In adults, penetrating neck trauma. Chronic for children and adults, both TB spine. Investigation, you just look into this picture. This is the vertebra. This prevertebral shadow is more than 1/3 of the vertebral shadow. Okay, I will repeat it. See, normally the prevertebral shadow should not be equal to that of the vertebra. This prevertebral shadow is almost equal to that of the vertebra diameter. Okay, which means that this prevertebral space is actually filled with some abscess. Okay, that abscess is most commonly retropharyngeal abscess. So if retropharyngeal space is not obliterated, if it is filled with abscess, now it could cause prevertebral shadow opening. Very, very important imaging point. Okay, treatment, incision and drainage under local anesthesia sitting position. If you do it under general anesthesia, you may injure the abscess and it will cause aspiration. So best method is sitting position and local anesthesia. That will be the best. Yeah, I will drop the mark PDF file. Yes, sure. Okay, not the original file. Then the most important point, abscess is parapharyngeal abscess. Very, very, very important. Okay. So see here, the parapharyngeal space is strategically very, very important point. Okay. So parapharyngeal space is divided into two parts. One is pre-styloid compartment. Another one is post-styloid compartment. Okay. Parapharyngeal space is divided into pre-styloid compartment and post-styloid compartment. So pre-styloid compartment is in front of the styloid process. Post-styloid compartment is just behind the styloid process. So post-styloid compartment is otherwise called as retrostyloid compartment. Number one. What is the superior-most boundary of the parapharyngeal space abscess? Skull base. Inferior-most boundary is hyoid bone. Now look at this picture. It will teach you a lot of important things. See here, you look at this picture, the space which I am talking about now is nothing but the area which is found over here. Can you see, pa? This is the parapharyngeal space abscess area. So what is the medial boundary? Can you see a muscle over there? That muscle is the bed of the tonsil. So medial boundary is bed of the tonsil. Lateral boundary is parotid glands, ramus of mandible, that you can easily appreciate. Okay. Superior boundary is skull base. Inferior boundary is hyoid bone. So when you look into this as a two-dimensional image, you could never ever appreciate it. Okay, that's point number one. Okay, fine. Now we are having styloid process, which divides the thing into two. See here, I'm going to hide this. Once I hide this, see here beautifully. Can you see? This is the hyoid styloid process which I am talking about. Okay, so styloid process is the process which divides this parapharyngeal space into two. Can you see? This is the styloid process which divides the parapharyngeal space into two. Now, what are the components of this pre-styloid compartment and post-styloid compartment? Let me tell you. Okay. One. So look into this. Can you see abundant of neurovascular bundle behind the styloid process? There is hardly any neurovascular bundle in front of the styloid process. Okay. So this is the post-styloid compartment. This is the pre-styloid compartment. So this pre-styloid compartment is hardly having any important structure. So if the abscess comes in the pre-styloid compartment, no much problem. Only problem is trismus and median bulging of tonsil. Number one. If the abscess comes in the post-styloid or retrostyloid compartment, there will be 9, 10, 11, 10 lobe palsy, jugular vein involvement, carotid involvement, sympathetic plexus involvement. So this is hell and heaven difference between pre-styloid and post-styloid thyroid compartment. See, just look into this. If you have to memorize just this, you can't just memorize it. You just have to imagine how where the space is located. Now, with the help of the three-dimensional MRI, which I have now showed it, you just now look into this. Pre-styloid compartment symptom is medial bulging of the tonsil. So, if it is medial bulging of tonsil, treatment can be given through the oral cavity, intraoral drainage of the abscess. If it is a retrostyloid compartment, 10, 11, 9, 10, 11, sympathetic plexus, carotid artery may be involved. So, you should do a external drainage for this patient. You should do a external drainage for this patient. Okay, fine. Okay. So, with that, we are completing parapharyngeal space abscess. Okay, fine. Anatomy and blood supply of tonsil. Tonsil, we are having descending palatine artery from maxillary artery, ascending palatine and tonsillar artery from facial artery, then small twigs from ascending pharyngeal artery, tonsillar branches from lingual artery. That's all. Valdes ring is the inner ring which is comprised of pharyngeal tonsil, tubal tonsil, palatine tonsil, lingual tonsil. Outer ring is comprised of cervical lymph. These are very easy points, not much to be known for. Now, the important point, tonsillitis and peritonsillar abscess. If you're having a tonsillitis, always bilateral. If you're having a peritonsillar abscess, always unilateral. Very, very important point. So, tonsillitis, if it is an acute tonsillitis, you are just going to give IV antibiotics. Point number one. If it's a chronic tonsillitis with repeated UR episode, you are going to do a tonsillectomy in rose position. So, tonsillitis, bilateral, acute IV antibiotics, chronic means surgery. Peritonsillar abscess, if it is unilateral, if it's always unilateral, no bilateral, always unilateral. Here it is pus collection between superior constrictor muscle and capsule of tonsil. Pus collection between superior constrictor muscle and capsule of tonsil. You will be doing a incision and drainage, and interval tonsillectomy can be done after 4 to 6 weeks. Interval tonsillectomy can be done after 4 to 6 weeks. Okay. Differential diagnosis for membrane over tonsil, very important DD. They could ask as multiple choice question. Okay. So, which of the following is not a membrane over tonsil? So, you should be knowing this: membranous tonsillitis, diphtheria, infectious mononucleosis, aphthous ulcer, agranulocytosis, leukemia. So, these are the differential diagnosis for membrane over tonsil. All right. So, another important abscess of the deep neck space is Ludwig's angina. See, Ludwig's angina, as the name goes, it is the angina means it's a very deteriorating condition. It could rapidly progress in a matter of 2 days and could affect the life of the patient. So, submandibular space abscess initially start as abscess, later can become cellulitis. Okay, here there is mixed bacterial infection occurring immunocompromised. The patient is rapidly progressive, and patients with tracheostomy, stridor can require tracheostomy. So, Ludwig's angina, submandibular space abscess, as the name goes, angina is very much severe, painful. The patient can rapidly progress. He may even require tracheostomy for treating the condition. Okay, fine. Okay. So, now we'll enter into larynx, the last part of our class. Okay. So, still few are here, few are there only. Fine. So, for you people, I am going to complete this in another 30 minutes or 25 minutes. Okay. So, anatomy of larynx. So, anatomy of larynx is very important. You should start with thyroid cartilage. Okay. So, thyroid cartilage is a shield-shaped cartilage. Okay. Its thyroid angle is 90° in males, 120° in females. You are having superior cornu and inferior thyroid cornu. Cricoid cartilage. Cricoid cartilage is a complete ring. Then there is signet ring shape. Okay. Epiglottis cartilage. See, let's have a bit of look into the anatomical orientation of the cartilages. You will feel refreshed. Okay. See here, beautiful depiction of anatomy, three-dimensional anatomy of larynx. So this is the hyoid bone. Okay, this is the thyroid cartilage. This is first unpaired cartilage. The membrane between hyoid and the thyroid cartilage is thyrohyoid membrane. Then you come little bit below. This is cricoid cartilage. This is cricoid cartilage. Okay. So the membrane between cricoid cartilage and thyroid cartilage is called cricothyroid membrane. It is called cricothyroid membrane. Okay. If you go just above, this is epiglottis. So we are having ligament between epiglottis and hyoid bone. It is called hyoepiglottic ligament. Okay. So this is step number 1. 3 unpaired cartilages: epiglottis, thyroid, cricoid. Now we are getting into posterior end. We are having 3 paired cartilages. Okay, having 3 paired cartilages. The cartilage number 1 is arytenoid cartilage. This arytenoid cartilage are 2 number pad which is placed over the cricoid cartilage. Cartilage number 2 is corniculate cartilage, which is placed over the arytenoid cartilage. Cartilage number 3 is cuneiform cartilage. 3 is cuneiform cartilage. So arytenoid, corniculate, cuneiform, 3 cartilages. Now you look at this beautiful membrane. This is called quadrangular membrane, which starts from epiglottis, anteriorly has attachment with thyroid lamina, posteriorly has attachment with arytenoid cartilage, inferiorly has attachment with false vocal cord. Very important membrane. So 4 attachments. Superiorly epiglottis. Okay, see here, this is the epiglottis. Anteriorly thyroid cartilage, posteriorly arytenoid cartilage, inferiorly false vocal cord. So there are 4 sides for this particular membrane. That makes the membrane very much important. Okay, fine. This is quadrangular membrane. Another membrane that starts below from the cricoid cartilage and ends at the true vocal cord is called as conus elasticus. So quadrangular membrane and conus elasticus are very much important to intrinsic membranes of the larynx. Okay, or the intrinsic membranes of the larynx. Now you look at this. Epiglottis is leaf shaped, attached to midline thyroid lamina, EC. Arytenoid is a paired cartilage involved in movement of vocal cords. Okay, arytenoid has 2 processes. One is muscular process having muscle attachment. Second one is vocal process that will have the vocal cords to get attached. So that will be important for voice production. Corniculate cuneiform has not much significance. Okay, fine. What are the other things? Laryngeal inlet. So laryngeal is nothing but this is the airway. The inlet that closes is called laryngeal inlet. So laryngeal inlet is formed by the free border of the epiglottis, aryepiglottic fold, interarytenoid area. Very easy to understand. See, from superior one side, then aryepiglottic fold, then interarytenoid area. This is called laryngeal inlet. Then the next point is epithelium of larynx. What is the epithelium of the larynx? The epithelium of larynx is ciliated columnar epithelium. Okay, whereas some areas doesn't have ciliated columnar epithelium except the fact that epiglottis, superior border of false vocal cord, true vocal cord. These 3 will be having stratified squamous epithelium. Why? These are not involved in function. To acquire protection, they need little bit more rigidity. So stratified squamous epithelium will give that rigidity for the patient. So what are the important structures? Mainly true vocal cord, a part of false vocal cord, both are having squamous epithelium rather than other parts are having ciliated columnar epithelium. Very, very important. Okay. So we discussed about the membranes. So let me classify the membranes into intrinsic membranes of larynx, extrinsic membranes of larynx. Under intrinsic membrane, I have already showed you quadrangular membrane starting from the epiglottis, anterior attachment thyroid lamina, posteriorly arytenoid, inferiorly false vocal cord. Then the conus elasticus starts from the cricoid, ending at the true vocal cord. So false vocal cord has quadrangular membrane, true vocal cord has conus elasticus. Very important. Extrinsic membranes. So membrane starting outside the larynx, ending into the larynx. Hyoepiglottic ligament, trichotracheal membrane, thyrohyoid membrane. So hyoid is outer, trachea is outer, hyoid is outer. So one outside structure, one inside structure. That is called extrinsic membrane. Functions of the larynx, mainly respiration and phonation. Here, fixation of chest and protection of lower airways. There is two spaces called paraglottic space and pre-epiglottic space. The paraglottic space is just parallel to the glottis. If this is involved, the tumor survival can be very difficult. Again, pre-epiglottic space, the CA supraglottis, if it involves pre-epiglottic space, means the tumor survival can be very much difficult. Okay, fine. With that note, we enter into the last part, the important anatomy and important pathology of larynx. Basically, infant larynx and adult larynx is quite different. This infant larynx is having C2, C3 level as the starting point. Epiglottis is flexible, and the important point, narrowest area is subglottis. Whereas adult larynx, C6 level is the starting point, epiglottis is stiff, and the narrowest is the subglottis. Narrowest is the subglottis. Now, what are the muscles that are developing and giving supply in the larynx? So, inner surface of the larynx has muscles such as abductor muscle, tensor muscle, adductor muscle. So, the abductor muscles are posterior cricoarytenoid. The tensor muscles are vocalis and cricothyroid. Apart from the tensor function, the cricothyroid also has some adduction function. That is the important reason for paramedian position of vocal cord in recurrent laryngeal palsy. Very important point. Okay. Adductor muscles are many. To mention a few, lateral cricoarytenoid, transverse arytenoid, and thyroidenoid can be put forth. Now, the important point, we should be knowing about the significance of vagus nerve. This vagus nerve comes out of the jugular foramen. Superior laryngeal nerve is given at the level of neck, whereas recurrent laryngeal nerve is given at the level of arch of aorta. Most important point. What is the big difference? Superior laryngeal nerve given at the level of neck will not go for damage very often, whereas recurrent laryngeal nerve given at the below can go above. In that area, it could be damaged by a tumor or a surgery or a trauma, many causes. So, recurrent laryngeal nerve, due to its recurring course, it is more prone for injury. It is more prone for injury. Alright. Now, to mention the nerve supply of larynx with specification, superior laryngeal nerve will supply the larynx till the level of vocal cord. Number 1. Below the level of vocal cord, hence sensory supply is by recurrent laryngeal nerve. So it's very easy. Sensory supply till vocal cord, superior laryngeal nerve. Below vocal cord, recurrent laryngeal nerve. That's all. Whereas motor supply for from the superior laryngeal nerve is cricothyroid. Whereas recurrent laryngeal nerve motor supply is very important and almost finished all muscles of larynx except cricothyroid. That's all. Now, during phonation, what are the positions the vocal cord can achieve? If the distance from the midline is 1.5 millimeter like this A is called paramedian. This B is called cadaveric, 3.5 millimeter from the midline. So if they ask from midline, it is 1.5 millimeter. If they ask between vocal cords, it is 3 millimeter. If they ask between vocal cords, it is 7 millimeter. Can you understand this point? This midline means from the midline they are measuring. You can also measure between vocal cords. That is also be measured. Okay. Then gentle abduction is 7 mm. Full abduction is 9 mm. So cause of vocal cord palsy is mainly central cause in superior laryngeal nerve and both nerve palsy. Whereas recurrent laryngeal palsies are the most local pathologies. Okay. So purely right-sided palsy is carcinoma lungs, apex of lung. Purely left-sided palsy is most important thing is Ortner's syndrome. We should never ever forget. Only left-sided Orlan palsy, left atrial enlargement, which is due to recurrent laryngeal nerve coming out of arch of aorta. That is the reason we are getting left recurrent laryngeal nerve palsy in Ortner's syndrome. Both Orlan, right and left Orlan palsy, you could see in thyroid surgeries. The surgeon may injure the nerve. Carcinoma of thyroid, carcinoma of esophagus, and cervical lymphadenopathy. Okay. So now comes the important point. Kindly pay attention. We are having 6 subdivisions for nerve palsy. We are having 6 subdivisions for nerve palsy. First, If the patient has only unilateral superior angina which is involved, there will be some huskiness of voice, and most importantly, the position of the vocal cord will be as Q position. Treatment is conservative position, nothing much needed. Okay. Whereas if it is a bilateral superior angiopalsy, severe huskiness, the change, no much change in the position. But as there is severe aspiration, there will be need for preventing the aspiration. So aspiration can be prevented by tracheostomy and feeding tube or epiglottopex. Tracheostomy and feeding tube and epiglottopex. Here, very important. See, only sensory division is affected, pa. Just have to do closure of the larynx. Respiration is normal, breathing is normal, huskiness only there. Only issue is aspiration. Whereas in case of recurrent angiopalsy, the problem is not aspiration. The problem is breathing. The vocal cords are becoming into the paramedian position. See here, this is the paramedian position which I am talking about. If the vocal cords come and meet in the paramedian position, there is no space for breathing. Again, I am saying this, recurrent laryngopalsy is the only condition where stridor will be seen. Bilateral recurrent angiopalsy is the only combination of no palsy which is having stridor. Rest all 5 combinations will not be having any stridor. But the most important thing, bilateral paramedian position, the patient will be stridor, hoarseness of voice will be there, but there will not be any aspiration. That much the SLN is concerned. Here, what we are going to do, you could do type 2 thyroplasty, which is called lateralization thyroplasty, point number 1. Or you could pull the vocal cords and do suturing. It is called lateralization suturing. You could pull the vocal cords and do suturing. It is called as lateralization suturing. Or you could do re-innervation procedures. Okay. Or you could do procedure called as Dennis-Kashima procedure, which is a combination of, see, this is a vocal cord. The posterior end of the vocal cord is removed, and also vocal process of arytenoid also removed. This is called cordectomy with arytenoidectomy. This is called cordectomy with arytenoidectomy. Okay, fine. So very important is bilateral oral palsy. Stridor will be there. Severe hoarseness, bilateral paramedian position. You should be treating the patient as early as possible. If you are not treating the patient, life can be gone. So you should do tracheostomy and plan for the intervention later. Okay, do tracheostomy, plan for the intervention later. Clear? Fine. Unilateral oral palsy, that much, it's not that much severe. The respiration will be normal, no stridor quoted, mild hoarseness, unilateral paramedian position. In this patient, if you feel that there is some hoarseness, you could inject Teflon paste. Inject Teflon paste for hoarseness. Clear? So very important, I have completed SLN palsy, aspiration is the problem. Bilateral RLN palsy, respiration is the problem. Bilateral both nerve palsy, speech is gone, aspiration very severe. See here, this is the position of the vocal cord. See, vocal cords are open. So no problem for breathing, but the problem is severe aspiration. The patient, the vocal cords can't meet in the midline. No speech at all. Aphonia. See here, aphonia. Bilateral cadaveric position. Okay. Respiration will be normal. See, bilateral oral palsy, stridor. Bilateral both nerve palsy, both SLN and oral going for palsy. Bilaterally, it is no respiratory problem. It is speech problem and severe aspiration problem. Okay, severe aspiration problem. So what you are going to do? You just have to suture the vocal cord, or you can do the tracheal diversion procedures. You are going to suture the vocal cord and or do the tracheal diversion procedures. Whereas unilateral both nerve palsy is important for one aspect. So unilateral cadaveric position. So you should try to bring the vocal cord to the midline. So here, medialization thyroplasty is done. There are 4 types of thyroplasty. Type 1 thyroplasty is done for unilateral both nerve palsy. Type 2 thyroplasty can be done for bilateral Arlen palsy. I repeat it. See, if the vocal cords are located laterally in bilateral Arlen palsy, okay, in bilateral Arlen palsy, what you are going to do? The vocal cords will be in the paramedian position like this. So you're going to pull the vocal cords laterally. This is type 2 thyroplasty in bilateral Arlen palsy. Okay. So it is not needed for unilateral Arlen, needed for only bilateral recurrent angular palsy or bilateral abdominal palsy. Now the vocal cords are in cadaveric position. Okay. Here you have to medialize the vocal cord. This is type 1 unilateral both nerve palsy. Unilateral both nerve palsy. Okay, unilateral both nerve palsy. Very important. Type 1 thyroplasty, unilateral both nerve palsy. Type 2 thyroplasty, bilateral nerve palsy. Please don't confuse yourself. If you have any doubt, ask right now itself. Okay. So vocal cord disorders. So vocal cord is having multiple layers. The squamous epithelium is superior, then basement layer. Then we are having lamina propria. We are having lamina propria number 1, which is superficial. Lamina propria number 2, which is intermediate. Lamina propria number 3, which is deep. This intermediate and deep lamina propria will be called as vocal ligament. Very important. But the superficial lamina propria is called as Reinke space. It's called as Reinke space. This Reinke space is having abundant of free space. So this can lead to edema called Reinke's edema. This will lead to edema called Reinke's edema. Okay, let me spit some facts. Video stroboscopy is an important investigation used for assessing hoarseness of the voice or benign diseases over the voice, over the vocal cord. So video stroboscopy is useful for assessing the benign conditions of the vocal cord. Very important. Then we are having dysphonia, which is of 2 types. Adductor dysphonia, adductor muscles goes for spasm. Abductor dysphonia, abductor muscles goes for spasm. The important thing in adductor dysphonia is, if it's a spasmodic dysphonia, you could treat. If it's a functional dysphonia, you can't treat, you just give psychotherapy. Abductor dysphonia, again, important point. The type 1 thyroplasty, which is done for unilateral both nerve palsy, can also be done for abductor dysphonia. It's quite critical point, but you should remember. Dysphonia 2 types: adductor dysphonia or abductor dysphonia. Adductor dysphonia, all the adductor muscles going for spasm. Abductor dysphonia, we are having only one abductor muscle, which is called safety muscle of larynx, posterior cricoarytenoid. So if posterior cricoarytenoid alone goes for spasm, it is called abductor dysphonia. You should be giving Botox injection or doing type 1 thyroplasty. Okay. Next dysphonia is dysphonia plica ventricularis. So normally, if you speak, that's no. Okay. If we try to do mimicry, if we try to do mimicry with different voices, then the persons can utilize the false vocal cord for speech production. Okay. If the persons use false vocal cord for speech production, it is called dysphonia plica ventricularis. We look into this. Voice is produced from false vocal cord. This is called dysphonia plica ventricularis. The voice is low pitched, rough, and unpleasant. The treatment is speech therapy for this patient. Another disease is called ulcer and granuloma over posterior third of the vocal cords. There will be a constant desire to clear the throat. Okay. The cause, if it is vocal abuse, we give speech therapy. If it is GERD, we give proton pump inhibitors to reduce the acid reflux. If it is granuloma, use steroids for the patient. So this is nothing but posterior 1/3 of the vocal cords due to constant rubbing over each other will result in the formation of granuloma. It is a sign of chronic inflammation happening at the posterior third of the vocal cord. Okay. So the chronic inflammation happening at the posterior third of the vocal cord is called as contact ulcer or contact granuloma. Okay, it is called. So there is this is called sulcus vocalis. That sulcus will be running parallel. So treatment is injection laryngoplasty. It's not much important. Another important topic is puberphonia. So puberphonia is nothing but 14 years male boys having female voice. Okay, in those boys, if you use your fingers and use your cartilage to go above, your voice suddenly changes. Okay, so puberphonia can be found clinically by Gutzman pressure test. This is the Gutzman pressure test. I am just applying pressure over the thyroid cartilage. That pressure will, for momentary, will make the males to female. The female voice suddenly changes to male voice. This is called Gutzman pressure test. It is done for puberphonia. Puberphonia, males having female voice. What is the treatment? Very important. Thyroplasty type 3. For androphonia, thyroplasty type 4. So we are having 4 thyroplasties. All of them are very, 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 very important. Okay. Type 1 thyroplasty is for unilateral both palsy. Okay, see here, and abdominal dysphonia. Type 2 thyroplasty is for bilateral abdominal palsy or bilateral palsy. Both are same. Okay. Type 3 thyroplasty, puberphonia. Type 4 thyroplasty, androphonia. So please memorize this. They may ask anytime. Okay. Type 1 is medialization. Type 2 is lateralization. Type 3 is shortening. Type 4 is lengthening. So very, very important table. You always read. Okay. Coming to the fag end. So vocal nodule is a singus nodule. The treatment is conservative. Vocal polyp is due to smoking and allergy. The treatment is microlaryngeal excision surgery. So a singer or a teacher, chronic voice abuse. They are always shouting like me. Okay. If they always shout like that, there will be formation of nodule. That nodule cannot be done by surgery. You advise the patient voice rest for 4 to 6 weeks, it will settle down. Whereas vocal polyp will not settle down on its own. You should do a surgery called microlaryngeal excision surgery. Okay, microlaryngeal excision surgery. So vocal nodule, causes of voice. Vocal polyp, causes of voice. Reinke's edema is due to hypothyroidism or smoking. Very, very important. Hypothyroidism or smoking. So I have already told you the vocal cord is divided into lamina propria number 1, number 2, number 3. The superficial lamina propria is otherwise called as Reinke's space. So edema over the superficial lamina propria is called as Reinke's edema. Okay, edema over lamina propria 1 or superficial lamina propria is called as Reinke's edema. Okay, so the treatment of Reinke's edema is decortication of cystic swelling. The treatment of Reinke's edema is decortication of cystic swelling. Clear? The fourth disease which is causing hoarseness of voice. These are the diseases which are causing hoarseness of voice because there is no proper junction of 2 vocal cords. Number 1 is vocal cord nodule. Number 2 is vocal cord polyp. Number 3 is Reinke's edema. Number 4 is vocal cord papilloma. Irregular finger-like projection over the vocal cord, multiple in nature, it is vocal cord papilloma. If it occurs in the adult, it is more recurrent. If it occurs in the juvenile age group, it is called as JORP. JORRP. Juvenile onset recurrent respiratory papillomatosis. It's very important disease. It occurs in juvenile age group. Causes of voice. You do a laryngoscopy, you will find multiple papilloma over the vocal cord. You do surgery, it will recur. To avoid recurrence, we should be giving agents such as alpha interferon, okay, or bevacizumab B, cidofovir, or ribavirin. These are the agents that can be used to avoid recurrence in papilloma. So these 4 diseases are very important because they will be causing hoarseness of voice. Those diseases such as dysphonia. Yeah, dysphonia is not a hoarseness of voice. Dysphonia plica ventricular is contact ulcer. Those are different. These are diseases which are benign lesions of the vocal cord causing hoarseness of voice. Very, very, very important. Okay, fine. Entering into diseases of larynx. See, it's very easy, very simple, and most commonly asked diseases two. One is acute epiglottitis, two is croup. Acute epiglottitis can affect unimmunized children as well as immunized children. If the acute epiglottitis, the causative organism is Haemophilus influenza or pneumococcus. What is the radiological sign? Thumbprint sign. Can you see? So X-ray neck lateral view. If you see for this patient, there will be thumbprint sign positive. The clinical sign for this patient is tripod sign positive. This tripod sign will create more space for breathing. That space will be adequate for air entry for this particular patient. Okay, tripod sign positive. Subacute infection due to parainfluenza virus A and B is called as croup or laryngotracheobronchitis. Both are same. Croup or acute laryngotracheobronchitis. Comparing these two diseases, acute epiglottitis is more severe and more problematic compared with croup. Okay, if you get epiglottitis, the patient immediately goes for stridor. They may require tracheostomy. Whereas in case of croup, the patient will not be so much distressed. You could give adequate hydration, antibiotics. It will make the patient eventually feel better. What is the most important thing? Acute epiglottitis, thumbprint sign, croup, steeple sign. Can you see the steeple? This is the steeple sign or church top sign due to subglottic accumulation of mucus. Okay, subglottic accumulation of mucus. Okay, so diseases of the larynx, we have completed acute epiglottitis and croup. The next disease is laryngoscele. Okay, so a small diverticulum. See, this is the false vocal cord. This is the true vocal cord. The area between false vocal cord and true vocal cord is called as ventricle. Kindly make a note of it. Very important point. The area between true vocal cord and false vocal cord is called as ventricle. From the ventricle, there will be a saccule coming laterally. So this is called saccule. So in persons with blow instrument as profession, like trumpet blower, nadaswaram blower, saxophone blower, there will be too much pressure between this area, between the true vocal cord and false vocal cord. If there is too much pressure at this particular area, that will lead to herniation of the laryngeal mucosa over the external premises. So that herniation of the laryngeal mucosa through the ventricle and saccule is called as laryngoscele. Very important disease. So here it occurs in trumpet blowers. They have asked this question many times in FMGE. Okay. So a small diverticulum from the ventricle of larynx is saccule. So the herniation of saccule is called as laryngoscele. The types of laryngoscele are internal and external. So clinically demonstrated by Valsalva maneuver. Okay. The gurgling sound that is heard over the swelling is called as Bryce sign. Okay. The gurgling sound that we hear over the swelling is called as Bryce sign positive. If the patient is symptomatic, you better do surgery. If the patient is asymptomatic, you don't have to do surgery. Symptomatic person, do surgery. Okay. The next important topic is Killian's dehiscence and the pouch coming out of Killian's dehiscence. Number one, a natural dehiscence which is found between cricopharynges and thyropharynges of inferior constrictor is called as Killian's dehiscence. Just look into this picture. We are having three constrictor muscles. Okay. Number one is superior constrictor. Number two is middle constrictor. Number three is inferior constrictor. This inferior constrictor is divided into two muscles. Number one is cricopharynges. Number two is thyropharynges. So between the thyropharynges and cricopharynges, we are having a empty space or weak space called as Killian's dehiscence. So this is the Killian's dehiscence which we are talking about. So in this Killian's dehiscence, if there is a chronic negative pressure over the Killian's dehiscence, there would be herniation of pharyngeal mucosa. There laryngeal mucosa and laryngoscele. Here herniation of pharyngeal mucosa. So herniation of pharyngeal mucosa through the Killian's dehiscence is called as pharyngeal pouch or Zenker's diverticulum. They have asked a lot of questions in these two topics. Okay, herniation of pharyngeal mucosa through the Killian's dehiscence. The clinical presentation very important. When the patient while upright, there will be settling of all the food particles into the pouch. No problem. The patient lies down at night. The accumulated food debris will come out and will create bad odor that is called halitosis. The patient will have halitosis and aspiration pneumonia. So the pouch which is regurgitating the foul smelling food particles will cause halitosis of the mouth, and then sometimes the food particles can enter into the airway causing aspiration. Very important. Pharyngeal pouch. You just look into this barium swallow picture. This barium swallow picture will be having a pouch that is looking like a diverticulum from the main pouch. Okay, pharyngeal area. This is the typical barium swallow picture of pharyngeal pouch or Zenker's diverticulum. The treatment is Dollmann's excision. We should remove the pouch and we should close the pouch. It is called Dollmann's excision. It is called Dollmann's excision. Okay, fine. Next disease of larynx is laryngomalacia. See, this laryngomalacia is the most common cause of neonatal stridor. The shape of epiglottis in laryngomalacia is omega shape. So this is not a serious disorder. The patient can be given reassurance that it will settle down. Reassurance enough for this patient. So reassurance enough for this patient. This omega shape epiglottis happening over 1 or 2 months old child, it will eventually settle down. Till then, give some conservative management like oxygen therapy or hydration. The baby will resolve. Okay, this is not a serious disorder, but it is most common cause of stridor. Okay, so TB larynx, you will be having pale laryngeal mucosa, turban epiglottis, laminated appearance of interarteria, mouse nibble appearance of vocal cord. Can you see the mouse nibble appearance? A lot of nibbled appearance over the vocal cord. These are the features of TB larynx. Okay, fine. Congenital subglottic stenosis. Okay, so grade 1 up to 50%, grade 2 51 to 70%, grade 3 51 71 to 99%, grade 4 no detectable lumen. Okay, so this classification is important for congenital subglottic stenosis. So treatment is excision and dilatation. Excise the subglottic stenosis and do dilatation. Okay, that brings us to the last chapter for the day, malignancy of larynx. The most common cause for stridor in a 60 years old male is carcinoma larynx. Why? In nasopharyngeal carcinoma, there will not be stridor. The sound that produced in nasopharyngeal carcinoma is called stertor. So no stridor. Acute severe asthma, you will be having these. Reinke's edema, no stridor. So the stridor in a 60 years male is typically a presentation of carcinoma larynx. So with that note, what is the etiology of carcinoma larynx? Tobacco, alcohol, or sulfuric acid. Okay. Now we are having some question. All of the following are true about glottic carcinoma, except. So it's more common in females. No. Usually seen over for 50 years. Yes. After laryngectomy, esophageal voice can be used. Yes. Good prognosis. The answer is females. All others are correct. It is usually common for males, not for females. Okay. Fine. See here. The presentation is very, very, very important. The clinical presentation divided into CA supraglottis, glottis, and subglottis. Okay. So we are having supraglottis with dysphagia as a symptom. So in CA supraglottis, lymphatic spread is highly common. Number 1. Carcinoma glottis, the symptom is hoarseness of voice, but comparing with other tumors, it is the most common tumor. Most common lymphatic spread, CA supraglottis. Most common tumor to occur, it is glottis. No lymphatic spread. Carcinoma glottic, no lymphatic spread. Very, very, very important. No lymphatic spread, CA glottis. More lymphatic spread. Commonest lymphatic spread, CA supraglottis. CA subglottis, no much important points. Dyspnea is very rare. Okay. So with this note, the treatment for, so the staging T3 is vocal cord fixity. T4A is cartilage involvement. For these tumors, we should be doing total laryngectomy. with RT. For T1, T2 tumors, RT alone enough. So this is a treatment for CLRIs. T1, T2, RT is enough. T3, vocal cord fixity, or T4A cartilage involvement, do total laryngectomy with RT. T4B, do a palliative RT. So with that note, we have completed the entire larynx. Okay. So we have a small discussion about the radiology in ENT. Okay. Radiology in ENT. See, this is the X-ray PNS Waters view. The Waters view open mouth view is called. Waters view is nothing but occipitomental view. The Waters view open mouth view is called. Pieris view. Okay, fine. The best view for accessing all four sinuses, the answer should be Waters view. All four sinuses, see here, the sphenoid sinus is seen through the mouth. Inside the mouth, you could see the sphenoid sinus. Frontal sinus, ethmoid sinus, maxillary sinus. You are seeing all four sinuses. It is Waters view. Okay. See, this is the occipit. This is the occipitomental view. Now, this is the occipit. This is the frontal. It is called occipitofrontal view or Caldwell's view. Okay. Occipitofrontal view or Caldwell's view. So this Caldwell's view is very important for viewing frontal sinus. If they ask you which is the best view for viewing frontal sinus, the answer is Caldwell's view. The Townes view is a superficial view of all structures. Superficial view of all structures. Okay. Townes view. Clear? So this CTPNS, very important. They have asked last time also. Please pay attention to this. See, look at this CT picture. This is a CTPNS coronal cut. So crown like this cut. Okay. So let me tell you a few points. This is inferior turbinate. This is middle turbinate. So these are all normal structures. So now you have to look for ethmoidal air cells and pneumatized turbinates. The turbinates are pneumatized or not, or if there are any abnormal or any some named ethmoidal cells are there or not. I will tell you with example. Okay, they asked last time also. So this is the pneumatized superior turbinate. Can you see? This is the pneumatized superior turbinate. So the marker structure is pneumatized superior turbinate. What are the answers for other options? What is concha bullosa? What is monodicell? What is Haller cell? So this ethmoid acid system is like a flour. We are making chapati. Okay. When we are creating duff, there will be a lot of air got stuck into the air cells. There may be a lot of named ethmoidal air cells. Okay. 4 ethmoidal air cells are very important and they are named. Number 1 cell is agar-nasae cell. Very, very important. They asked last time, they asked this time also. Agar-nasae cell. The anterior most ethmoidal air cell. Anterior most ethmoidal air cell is called agar-nasae cell. The anterior most ethmoidal air cell is called agar-nasae cell. Okay, fine. The consistent ethmoidal cell. The most consistent ethmoidal cell is ethmoidal bulla. 2 named ethmoidal air cells done and dusted. Very important. Kindly pay attention. So most anterior most. See, this is the location of agar-nasae cell. This is the location of ethmoidal bulla cell. Now look at this. So just been locked or clubbed over here. See, this is the area. Infraorbital cell. See the arrow mark. See the arrow mark. Infraorbital orbital cell. The cell that is found below the orbit is called as Haller cell. The cell that is found below the orbit is called Haller cell. The posterior most air cell is called as Onodi cell. Very, very important cell. Posterior most. Onodi cell. Onodi cell lies close to optic nerve. The Onodi cell lies close to optic nerve. So 4 cells. Agar cell anteromost. Ethmoidal bulla most consistent. Infraorbital cell Haller cell. Onodi cell posterior most cell. Okay, fine. The pneumatized superior turbinate I have told you already. So what are the CT findings of this is the Haller cell, Haller cell. Okay. So this is the homogeneous opacity seen in bacterial sinusitis. Can you understand, Pa? The opacity is uniform. Homogeneous opacity. It is bacterial sinusitis, chronic sinusitis. If there is heterogeneous opacity, can you see the difference? It is uniform. It is uneven. Heterogeneous opacity is seen in fungal sinusitis. Okay, fine. Now, polyposis. See, this is the anthracoidal polyp. Can you see? This is the ethmoidal polyp. Anthracoidal polyp is a polyp that comes out of antrum. Antrum is nothing but entry point for maxillary sinus. Choana is the posterior end of the nasal cavity. So anthracoidal polyp starts from antrum, ends till the choana. This is ethmoidal polyp arising from the ethmoidal axis. This is after FES. So after FES, complete removal of all the air cells opening, and we are giving clearance. So this is an important question. So unit nasal obstruction, foul smell and discharge. So this is a picture of inverted papilloma. So not much important. Just for showing, I have kept here. Okay. So a child present with biphasic stridor, X-ray image is given. What is the diagnosis? Kindly please answer. Easy question. To answer this question, we could complete the class. Child with biphasic stridor, given X-ray image shows what of each of the following. Please answer. Please answer. Still, there are few people remaining in the chat. Dr. Gaurav, Dr. Jayaprakash, yes, Dr. Tamanasan, you are correct. It is steeple signs seen in or church top signs seen in acute laryngeal bronchitis. Great. Okay. Now, at only a child present with difficulty in swallowing, present with the following X-ray. This is the X-ray. Where would be the foreign body located? Esophagus, trachea, soft tissue like mediastinum. So, if you see a static foreign body like this, it is definitely esophagus, because foreign body over the trachea, mediastinum, soft tissue neck will not be static. It will go into lungs. So this esophagus foreign body settle at cricopharynx. Okay, settle at cricopharynx. The coin in the esophagus. You're perfectly correct. If it is to be more precise, the cricopharynx is the actual location in the esophagus, starting point of esophagus. Clear? So, young male suddenly developed choking episode while eating in a restaurant. What will he do next? So, the answer is Heimlich maneuver. Correct. This is a question from the last year FMGE. A child person with sudden breathlessness, stridor tachypnea. What is the immediate investigation advice for this patient? Sudden breathlessness, stridor tachypnea. Child. Answer? Okay. See, if there is sudden breathless stridotachypnea, what are the DDs? It could be foreign body. It could be epiglottitis. It could be croup. Whatever be the case, this direct laryngoscopy is not a OPD procedure. This should be done in a OT. Ideal, not enough. So if the child is presenting some acute symptoms, you take the X-ray, you rule out the foreign body, you can confirm it as epiglottis or croup, and then you can proceed. So this is how you should proceed. See, direct laryngoscopy is not an easy procedure. This is a procedure should be done in operation theatre. Okay. So with that note, I will give you some insights for foreign body management. Okay. So a child, adult, if you are suspecting a foreign body at the oral cavity, for example, if there is some kid in your house, your sister's kid or brother's kid, if you are suspecting the foreign body in a child, you should do oral sweeping movements. What is this oral sweeping movements? See, we should put the fingers into the mouth to pull out the foreign body. So we are just, the child will not say I have put in the foreign body. So if we are suspecting now, oral sweeping of mouth should be done. Adults has no suspicion. Okay, they are very sure about that. They have swallowed or not, they know very well. So no point in that. Throat, if it has fixed in throat and cause choking, okay, to do this. A, B. A is chest thrust and back slap. With this movement, if you apply chest thrust for this child, the foreign body which is present in the throat will come out by negative pressure. This is a modified Heimlich maneuver in children. So this is Heimlich maneuver for adults. This will bring out the foreign body. Okay, fine. Next one. If it has entered into esophagus, it has entered into bronchus. If it has entered into esophagus, you do esophagoscopy and remove. Bronchus means bronchoscopy and remove. So third level. Okay. So if it is at the mouth, na, you do sweeping movements, number one. At the throat, na, you do some first aid. It is either chest thrust and back slap for child, Heimlich maneuver for adults. If it is entered into the esophagus or bronchus, na, you could do esophagoscopy or bronchoscopy depending upon your requirement. All right. So that completes our discussion. Okay. Now we can solve MCQs from FMGE. A child with throat pain and fever has whitish membrane tonsillar region which bleeds on scraping. What is the possible diagnosis? Please answer. Please answer. What is the answer for this question? Which bleeds on scraping. It is diphtheritic tonsillitis. Other tonsillitis will not bleed on touch. It is diphtheritic tonsillitis. Correct? Super. A young male who is a professional trumpet blower present with swelling on left side Gurgling sound, compression swelling. X-ray of neck is not given here. Answer is laryngocele. Super. 65-year-old male presents with history of dysphagia, halitosis, aspiration pneumonia. Variant follow is done, given not, which is not there. Answer is yes, Gaurav. What is the answer? Yes, xanthous diverticulum, or otherwise called pharyngeal pouch. Okay, fine. Following right hemianoplasty for female patients is the weakness of voice and inability to raise the pitch. Askew position of vocal cord. If there is askew position of vocal cord, what is the answer? It is unilateral superior laryngeal nerve palsy. Bilateral S1 palsy, no positional difference. Unilateral S1 palsy, askew position. Right superior laryngeal nerve palsy. Right superior laryngeal nerve palsy. Okay, fine. Structure not seen in indirect laryngoscopy. Structure not seen in laryngoscopy. Base of tongue will be seen pa. Pyriform fossa will be seen pa. Glottis also seen pa. Subglottis only not seen pa. The pyriform fossa, if the answer is apex of pyriform fossa, you could choose it. Not only pyriform fossa. Subglottis never seen. Subglottis never seen. So best answer is subglottis. What are the other structures that are not seen? Laryngeal surface of epiglottis. Then anterior commissure of glottis. Okay. Safety muscle of larynxes. Only muscle which is abducting, which is the safety muscle. Safety muscle means if the patient, the vocal cords move away from each other, there will be adequate space for respiration. So respiratory muscle which abducts will be the safety muscle. Which is the muscle which is the only abductor in the body? Which muscle is the only abductor? Other muscles are adductors. Answer please. Only abductor muscle in the body is called a safety muscle because abduction will bring the vocal cords away from each other. That will provide space for breathing. Okay, it is posterior cricoarytenoid. Okay. So we have almost solved all the MCQs from the last 5 years. We have completed almost 90% of which one? Why not see? Cricoarytenoid. Cricoarytenoid will not do abductor. Abduction is the only function of posterior cricoarytenoid. Oh, so there is another cricoarytenoid called lateral cricoarytenoid, oblique cricoarytenoid. Okay, so it could be that. It could be a lateral cricoarytenoid or transverse cricoarytenoid. So specific thing is posterior cricoarytenoid is the only muscle which is abductor. The question is correct, but there are a lot of cricoarytenoid muscles which is having lateral, transverse, oblique like that. But posterior cricoarytenoid is the only muscle which is having abductor function. Okay. See here, I have discussed for almost 5 hours. Okay, 5 hours. Usually the FMGE class itself I will take for around around 18 hours to 19 hours. Okay, that's all. I have taken almost half of